Hey guys, so let's continue our discussion about ischemic heart diseases. So in this video, I'll talk about the diagnosis and the treatment. So for diagnosis, we know that we have different types of ischemic heart diseases, right? So we can use an ECG and some biomarkers to help us distinguish which type of ischemic heart disease we're dealing with in a specific case. So if we get a patient coming in with ischemic chest pain, we can ask for an ECG first and then biomarkers as well. So for a stable angina, recall that in stable angina we have subendocardial ischemia, no infarction. So in this case with the ECG, we're not seeing any ST elevation because there's no transmural involvement, all right? So no ST elevation, and because there's no infarction, troponin, which is one of the biomarkers that we can order, it would be negative because there's no cell death, there's no infarct, it's just ischemia in this stage. So just to summarize, for stable angina, no ST elevation on the ECG, troponins would be negative. For a princemetal angina, which is the vasospastic or the variant angina, we have transmural ischemia. So with transmural ischemia, we have ischemia from the endocardial layer, from the endocardium to the epicardium. So that whole myocardial layer has been starved with oxygen. It's ischemic. But for troponin, it would still be negative because we still do not have any infarction, okay? ST elevation will be seen on the ECG because of that transmural involvement. So to summarize, in princemetal angina, our ECG would show ST elevation and troponins would still be negative. For our acute coronary syndrome, so we have unstable angina, NSTEMI, and STEMI. So for unstable angina, recall that in this scenario, we still have just subendocardial ischemia. So we don't actually get any ST elevation on the ECG. Also, because there's no infarct, troponin would be negative. So for unstable angina, we're gonna get no ST elevation. We might see some changes like ST depression and T-wave inversions, but no ST elevation. And troponin would be negative, okay? For NSTEMI, so for NSTEMI, what we're gonna get on the ECG, because now we have some subendocardial infarct. So the ECG would not show us ST elevation. It will show maybe ST depression and T-wave inversion, but no ST elevation. But because now we have some of the tissues that died, because now we have an infarct, troponin would be positive, sorry. So to summarize, NSTEMI, we are not gonna get ST elevation, but we might see ST depression, T-wave inversions. But troponins would be positive because now there's an infarct. For STEMI, because it's now a transmural infarct, so cells have died from the endocardium to the epicardium, we are going to get ST elevation. And because, again, there's infarct, we're going to get troponin. So troponin would be positive. So to summarize, STEMI, we're going to get ST elevation and troponins would be positive. Okay, before we move on, I just want to quickly discuss some of the biomarkers. So I already spoke about troponin, but we also have another one called CKMB that we could order and check if there's a STEMI, okay? If there's transmural infarct. So, okay, in a myocardial cell, these biomarkers, these molecules are contained inside them, and they are released from the myocardial cell if there's tissue damage, okay? So the only really difference is basically they would both be elevated if we have a STEMI. The only difference is CKMB takes a much longer time to normalize. Okay, I wish I could show you guys a graph to explain this, but CKMB and troponin, they take around about the same time to reach their peak. So it takes about about 12 to 24 hours for CKMB and troponin to reach its peak point before they start to decline. But CKMB normalizes way faster than troponin. So we could use this as an advantage because, for instance, you have a patient who came in with chest pain, and then you do an ECG, shows ST elevation, you check troponin, and it's positive. Now you know you have a STEMI. And then you deal with that, and then a couple of days later, the same person comes back and complains about chest pain again. So at this stage, troponin would still be raised. Troponin would still be elevated, but CKMB, they've already normalized. So what you can order another CKMB, and because at this point, CKMB would have normalized, if there is a reinfarction, CKMB would then elevate, okay? So I hope that's clear how you can use CKMB to check for reinfarction. But these biomarkers would both be elevated if there is a transmural, if there is an infarct, okay? Subendocardial infarct or transmural infarct, as long as there's like tissue death, tissue damage, okay? Just for additional info, we can use other diagnostic methods and equipment to help us diagnose NSTEMI and STEMI. So for these types of ischemic heart diseases, we could use an echo. So an echo would show wall motion abnormalities, right? I don't have time today to talk about how exactly that works, but you just have to remember an echocardiogram would show wall motion abnormalities for these types of ischemic heart disease. Also, we can use cardiac catheterization, okay? So this is probably the best one to use for NSTEMI and STEMI, especially for STEMI, because what we can do is we can visualize exactly how much the artery has been blocked by this clot. It's not only diagnostic, but it's also therapeutic. So right then and there, when we see, oh, you know, this artery is occluded by 96%, right then and there, we could treat that. You know, we could put like a therapeutic intervention. So we could put like a stent to hold it open, to hold the artery open. So this is why it's very good. Cardiac catheterization is very good because it's not just diagnostic, it's also therapeutic. Sorry guys, I had to recharge my phone. So I think we stopped talking about diagnosis. So moving on to treatments. So the first thing that we can do to treat ischemic heart disease is to reduce the risk of thrombosis. So we can achieve this using different drugs. So first of all, we can use aspirin. Aspirin is acetylsalicylic acid. So the way that this works is it inhibits the COX enzyme, which converts arachidonic acid to many different things, to prostaglandins and to like thromboxane A2. So thromboxane A2 is responsible for platelet aggregation. So if we inhibit the COX enzyme, we decrease the amount of thromboxane A2 being produced. So we reduce the risk of platelet aggregation and therefore reduce thrombosis. The next one that we can use is just a much stronger version of aspirin. So we can use P2Y12 receptor inhibitors like ticagrelor or clopidogrel. So P2Y12 receptor inhibitors obviously inhibit P2Y12 receptors. So these receptors is basically where ADP binds onto, and then that triggers the aggregation of platelets. So if we block this receptor, ADP cannot bind onto these receptors, and therefore platelets can't aggregate. They can't stick to each other, therefore reducing thrombosis. So that's how these drugs work. And they're a lot, so they kind of act on the same sort of mechanism, but they're a lot stronger than aspirin, okay? The third one is heparin. So heparin is beneficial if the patient is also eventually gonna go to a cath lab. Otherwise, it's not superior to the other ones that I've already mentioned, to aspirin and to P2Y12 receptor inhibitors, clopidogrel and ticagrelor. So Heparin, again, so many types. There's fractionated, unfractionated, low molecular weight. So I don't want to get into the mechanisms of all of this, but all I want you to remember is that heparin, how am I going to say this simply? Okay, heparin basically increases the activity of antithrombin 3. Yeah? So antithrombin 3, as you've guessed from the name, inhibits thrombin and factor 10. So thrombin and factor 10, they start a coagulation cascade that leads to the formation of a fibrin mesh. Okay? So this fibrin mesh stabilizes that clot. So if we give heparin, we increase the activity of antithrombin 3, and then we basically decrease the activity of factor 10 and thrombin, so we don't get that fibrin mesh. So we decrease thrombosis. So that's how it works. Again, there's different types, but all I want you guys to remember is that simple mechanism. And again, it's superior to the other ones if the patient is going to cath lab eventually, but other than that, it's not superior to the others. They still use the other ones first, okay, basically. The fourth one that we can use is statins. So statins don't reduce thrombosis per se, but like it reduces plaque formation, okay, which is what is responsible for that atherosclerotic plaque in the first place. So statins, they work by reducing LDLs and increasing HDL levels in the blood. So hopefully by doing this, we, reduce the chance of a plaque forming in our coronary arteries, okay? So that's statins. The fifth and final one, so we need to modify and address any risk factors. So for instance, if the patient is diabetic, then we need to advise the patient on like proper blood glucose control. If the patient is a smoker, then he stops smoking. The other one is hypertension, right? So hypertension is a big risk factor for atherosclerosis. Remember, bad heart, H is for hypertension, so it's one of the risk factors. And actually, for this, we can give the patient ACE inhibitors. So ACE inhibitors, obviously they inhibit the ACE enzyme. The ACE enzyme converts angiotensin 1 to angiotensin 2. So angiotensin 2 has loads of different effects, but in general, what it does is it increases blood pressure. So if we give ACE inhibitor, we decrease the person's blood pressure. And on top of that, we give ACE inhibitors because it reduces cardiac remodeling, especially after an MI. So it's gonna help in that sense as well. Just to give you guys an example, ACE inhibitors include enalapril, lisinopril, and captopril. The second way that we can treat ischemic heart disease is by reducing oxygen demand and oxygen consumption. So we can achieve this by giving nitroglycerin. So nitroglycerin, it vasodilates specifically the coronary arteries. So it just dilates the coronary arteries, making making easier for blood to flow through them. The second one that it does, it like dilates the veins. Okay, so it's a venodilator. So when you dilate the veins, you decrease the resistance, you drop the blood pressure. That's one thing. The second thing, when you dilate the veins, that actually reduces venous return, okay? Because think about it, you're not squeezing the veins so hard, so there's not much pressure trying to push blood back to the right side of the heart. So you're decreasing the preload. When you decrease preload, you decrease stroke volume, and when you decrease stroke volume, you're decreasing right ventricular workload. You're decreasing the work that the left ventricle needs to put in to pump that blood through the systemic circulation. So you're making it easier for the heart, okay? And this means that it doesn't have to consume as much oxygen because it's not working as hard. So that's how nitroglycerin works that's how nitroglycerin reduces the demand and the consumption of oxygen. It makes it easier for that right ventricle to do its job, okay? You need to be careful though, because this is contraindicated in patients that are preload dependent. Remember that it's a venodilator, which decreases venous return, decreasing the preload, right? So if a patient is preload dependent, you cannot give nitroglycerin. So what do I mean by preload dependent? So for instance, if we have a patient with a right ventricular MI, an MI in the right ventricle, which means that the right ventricle isn't contracting as like hard and as efficiently as before, because it's some of the tissues have infarcted. They're not like very strong, okay, and very good at contracting. So in this case, if we give nitroglycerin, it's going to decrease the preload. And remember that stretching of the ventricle is essential, because the more the stretch, the higher the force of contraction. Remember Starling law. The more the stretch, the greater the force of contraction. So if we decrease preload in this case, where there's a right ventricular MI, then that ventricle isn't really gonna stretch as much, so it's definitely not gonna contract as hard to push blood to the lungs. Okay, so that's why we don't give this in patients that are preload dependent. The next drug that we can give is morphine. So morphine is a painkiller. At the same time, it's a vasodilator. So it dilates the veins just like nitroglycerin. So when we dilate the veins, we decrease venous return, we decrease preload, we decrease stroke volume, we decrease the workload of the left ventricle. And that's decreasing the oxygen consumption and oxygen demand. But at the same time, it also decreases afterload. It also dilates the arteries. So when it dilates the arteries, the resistance goes down. Therefore, the left ventricle doesn't have a high resistance to overcome to push that blood out. It decreases the afterload. So it makes it easier for the left ventricle to pump that blood out to the systemic circulation, which means less oxygen demand and less oxygen consumption. So morphine is only given if it's not the first line, okay? So morphine is just given if the patient is refractory to nitroglycerin. Nitroglycerin is always given first, and then if that doesn't work, then we give morphine. The third drug that we can give to lower the oxygen demand or the oxygen consumption is beta blockers. So remember that beta receptors in the heart are in the SA node, the AV node, and the actual myocardium. So if you use beta blockers to block the beta receptors on the SA node and the AV node, we would decrease the heart rate. If we decrease the heart rate, the heart is not beating as fast, therefore it's not going to require as much oxygen. Therefore, we're decreasing the demand for oxygen, okay? So that's how beta blockers work. Also, we have beta receptors in the actual myocardium itself. So if we use beta blockers, then that's gonna not make the myocardial cells contract as forcefully. So we reduce contractility, and by reducing contractility, we reduce the demand for oxygen as well, and therefore we wouldn't need as much. So that's how beta blockers can help in this situation. Also, another way to address ischemic heart disease is by increasing oxygen supply. Remember that mismatch. So sometimes what happens is that we have adequate supply, but we have such a high demand, or we just don't have enough supply. So the way to resolve this mismatch is if we don't have enough oxygen, the only way to increase oxygen really is to give supplemental oxygen. So we can give the patient supplemental oxygen, especially if they're hypoxic. So this is the only thing we could do to increase oxygen levels. The other drugs I mentioned previously are to decrease the demand of oxygen. The final method that we can use to treat ischemic heart diseases is revascularization. So revascularization, or the opening up of the arteries again, is probably the best thing you can do for the patients. I mean, reducing thrombosis, reducing oxygen demand, increasing oxygen supply, they're all good, but this is the best way to address this problem, especially if this is like an unstable angina, an NSTEMI, and a STEMI. So revascularization, we have two techniques. So the first one is called angioplasty, or cardiac catheterization. So this is what happens when we send patients to a cath lab. So angioplasty simply means that we thread a catheter through the radial or the femoral artery all the way up to the coronary arteries, and then we just locate the areas of obstruction. So that's the first part. And then the second part is, if when we locate the obstruction, we can then use like a balloon to open it up, to like squish and push the plaque to like the vessel wall to reopen that lumen, okay, of the artery. Also, we can thread a stent in to hold that in place, to keep that artery patent. So this whole process is called PCI, percutaneous coronary intervention. Okay, so that's the first way. The second way is a CABG. This is an open heart surgery. So CABG, we use this if, for instance, we can't fix the occlusion using a PCI, or the vessel that's occluded, the artery that's occluded, is a major coronary artery that's branching off to other smaller arteries, okay? So if we have occluded a major artery, coronary artery, then we might be better off doing CABG. Because, otherwise we stop blood flow to a lot of smaller arteries. So how this works is that we basically take like veins from the leg, so like the saphenous vein, or arteries like the internal mammary, the internal thoracic, or even bits of the radial artery. We take them as a graft, and we use this to form like a new route, like a so for instance, this is the occluded artery, right? So for instance, this is the occlusion, this red thing here. So the graft, so for example, I took a bit of my saphenous vein, and then I just do like, I connect that to this end to this end, okay? So I connect it like that. So in this way, I'm bypassing the obstructed bit of the artery, and I'm redirecting blood flow from here all the way straight to this end, okay? And this then reperfuses the other tissues that have been starved with oxygen. So that's how CABG works. Sorry guys, I forgot to mention that in PCI, we have this like golden time. We have a specific amount of time that we need to get the patient who sat in A&E complaining of chest pain to the cardiac catheterization lab to actually get their blocked artery open up via that balloon catheter and that stent. So we call this the door to balloon time, I think, door to balloon time. And this is like equal or less than 90 minutes, all right? So we have 90 minutes to get this done. And also for PCI, I forgot to mention the stents that we use. We have two different types of stents. We have bare metal stents, which is a lot less commonly used nowadays, and the drug-eluting stents. So drug-eluting stents, they have a drug in them that prevents like cell proliferation and growth around the stent, and therefore like reduces the risk of stenosis and fibrosis. But drug-eluting stents are still, at risk of rethrombosis, so it can still rethrombose. So for this reason, anyone that that goes through this process of percutaneous coronary intervention and uses a drug-eluting stent, we need to put them on a dual antiplatelet therapy. So we put them on aspirin plus clopidogrel or ticagrelor for a year. And then after a year, the clopidogrel or ticagrelor can go away, but we still put them on aspirin, okay? Just to reduce that risk of rethrombosis within that stent.